webinar series. I am Sheila Siar, and I will be moderating this event. For our first webinar, we will look at the novel coronavirus disease pandemic, one of the most daunting health emergencies the world has experienced. Specifically, we will discuss its potential socioeconomic impacts on the Philippine health system and the macroeconomy. But before we start, I would like to inform you of our house rules for the efficient conduct of this virtual seminar. First, may I request everyone to please reserve your questions until the end of the presentation. Second, for those of you who would like to ask a question during the open forum, please write your name, your first and last name, and your affiliation in the chat box located at the lower part of the screen. And during the open forum, I will call your name according to the sequence that your name appears in the chat box. You may do this, you may write your name on the chat box during the open forum or while the presentation is ongoing. Third, kindly mute your microphones when not speaking to avoid background noises that may distract the speaker and other participants. And please don't forget to turn it on when you're about to speak. And lastly, the proceedings of this webinar is recorded for documentation purposes, but it is possible that we will share the recording through our website and our social media pages. So to formally start our program, I now invite our President, Dr. Celia Reyes, to give her opening remarks. Ma'am Cel?
Yeah. Good afternoon, everyone, and apologies. Having problems with my video, but I'd like to welcome our guests, colleagues from the government, representatives from the academe, civil society, media, and the private sector to our webinar this afternoon. With new technologies, physical distance is no longer a barrier. We can still exchange ideas and interact with one another, even if we're not in the same room. With enhanced community quarantine in place, we at PIDS have been conducting our internal research seminars using teleconferencing activities. Today, we're holding our first webinar to disseminate to the public the studies that PIDS has conducted. This afternoon, we're happy to share with you the results of the study conducted by our health team on the COVID-19 pandemic. PIDS Senior Research Fellow Michael Abrigo, Research Fellow Valerie Gilbert Ulep, and Supervising Research Specialist Jhanna will walk us through the different scenarios to show the potential impacts of the pandemic on both the country's socioeconomic and health sectors. In addition, they will give their recommendations for moving forward, which inarguably is the next big challenge that our country is facing. According to the latest report of the Department of Health, there are 11,618 confirmed cases, 772 recorded deaths, and 2,251 recoveries as of Wednesday, May 13. Globally, there are about 4.2 million confirmed cases and about 290,000 deaths, according to the World Health Organization. In addition to the health related impacts, the economy has been badly affected. The Philippine economy has shrunk for the first time in 22 years as GDP declined by 0.2% in the first quarter of 2020. The last time the GDP contracted was in 1998 due to the Asian financial crisis. During the first quarter of 2020, accommodation and food service activities contracted by 15%. Transportation and storage sector went down by 11%, while the manufacturing sector, which accounts for about 20% or one-fifth of domestic output, declined by 3.6%. According to our research team, the economy can suffer a loss of as much as 2.5 trillion pesos for the whole year under the worst case scenario. While there are no recent data, we expect unemployment rate to be much higher than the 5.3% posted in January 2020, as many firms had to stop operations in ECQ areas. Reopening the economy to save people from hunger may lead to a resurgence of the coronavirus disease and consequently more deaths unless the necessary health standards are in place. How to balance economic hardship with a public health hazard is a very difficult decision, being faced not only by the Philippine government, but by the other 180 countries with COVID-19. The Philippine government is doing everything it can to slow down the transmission of the virus and cushion the adverse impacts of the pandemic on the economy. The business sector, academia, civil society, and the media are also doing their part. This is a crucial period for all of us to work together because we do not know when this outbreak will end. The situation calls for us to be vigilant and prepared for whatever possibilities that this pandemic may bring. Through this study, PIDS hopes to contribute to the ongoing discussions of policymakers and government leaders by presenting the projected resource requirements needed by the health sector to cope with the demands of the pandemic, as well as strategies on how to minimize its negative effects on our economy. It's good to know that we have a diverse set of participants in this webinar. A good representation of sectors in one meeting will give us the opportunity to listen to each other and share our thoughts on how to face the challenges that come with the COVID-19 pandemic. So let me thank everyone who are here for taking the time to join this webinar. Virtual conferences and webinars have become the new normal. So please expect more online events like this from PIDS from now. We look forward to hearing your insights during the open forum. Thank you.
Thank you very much, Mamsel. So we now proceed to the research presentation, but first allow me to introduce the authors briefly. So three of them are from PIDS. Michael Abrigo is a senior fellow at PIDS where he works on population, health, and nutrition policy issues. Prior to his return to the Philippines, Michael was a postdoctoral fellow at the East West Center in Honolulu, and he obtained his PhD in economics from the University of Hawaii at Manoa. Val Ulep is also a research fellow at the PIDS, and prior to joining the institute, he worked at the DC and Delhi offices of the World Bank. He has a PhD in health policy and economics and a master's degree in epidemiology. Jhanna is a supervising research specialist at PIDS, where she conducts research on health systems, reforms, and policies. She recently obtained her master's degree in epidemiology from the Harvard School of Public Health. The rest of the authors, namely Dr. Kris-Francisco Abrigo and Mr. Jason Ho, are consultants of the Institute. So over to you now, Mike, Val, and Jhanna for your presentation.
Thank you so much, Sheila, for the introduction and Mamsel. Um, First, this is my first time to have a public webinar, and it's really different not being able to see the faces of the people you talk to. But having said that, let me thank the team that has worked on this report. So Val, Jhanna, Chris, and Jason. Uh, from Sheila's introduction, the team is composed of people from very diverse backgrounds, but mainly from health, epidemiology, economics, South economics, public economics. So, and we also want to thank the people who has looked into this paper even before it was sent out publicly, because these has helped how the discussion was shaped, and we were able to they were able to see through our blind spots. And so it really has enriched the paper. About the paper, just a brief overview, background. we started working on this paper when COVID-19 was like started here in the Philippines. Nagsimula siya actually nung uh, then the chair, Secretary Pernia, asked PIDS as a as a head of the board of trustee to look into the potential impact of COVID-19 in the Philippine economy, and we started working on this uh, middle of March, and we really don't know anything about COVID-19 during that time. The world is in panic. It's a growing pandemic, and over the next month, from March 15 until the paper was released, we've actually updated a number of times because of new information about the epidemiology of COVID-19 and how it has progressed in the Philippines. Next slide, please. Next slide, please. So, in the report, if you were able to read it, there are a number of sections. And that would be the outline of our presentation. So in the first part, we would discuss the projection model that we used. And using that model, we were able to project what's the potential impact of COVID, what's the potential magnitude of COVID-19 in the Philippines, given different policy levers that at that time we were thinking that the government may use. And using this projected outbreak, projected epidemiology in the Philippines, how would that impact the health system resource requirements to be able to deal with the epidemic? And then moving forward, what does that mean for the economy? And then we would close the presentation with recommendations. For the first part, we would have Ms. Uy to talk about the model, and then I would go through the economy-wide impacts, and then Dr. Ulep would go through the recommendations. Uh, Jhanna?
Okay, thanks, Mike. So good afternoon, everyone. So again, the first objective is really assessing the potential trajectory of COVID-19 in the Philippines using a disease transmission model with inputs using Philippine data and also literature. So next slide, please. Sorry, next. Yeah. So before anything else, here is an overview of our data sources for the disease transition model. The data for our model really came from two sources. So that's first, syempre the DOH, Epidemiology Bureau, namely the data on confirmed cases and deaths. And also duration of certain events, like for example, what is the time from symptom onset to when patients seek care, from the time they seek care, when do they get their test confirmations, from the time they get confirmed, how long before they recover or they die, or do they die. The other part was really from literature because, as we know, in early disease outbreaks, surveillance is really difficult. And there was a lot of data for validation in EB. So for some parameters in our model, we really had to refer to literature, more specifically the Chinese literature, the literature from Wuhan, because their outbreak was almost complete and they had a better picture of other parameters. So on this side of the slide, to the right, you can see really what is the system of DOH for COVID-19 surveillance. So as we know, the Philippines has a decentralized government, so that also applies to disease surveillance. So what happens is that in every administrative level in the government, there are designated epidemiology and surveillance units. And these units are in charge of, say, contact tracing, case investigation. The health providers report to them whether they are suspected cases of COVID-19. And so that cascades up from cities and municipalities submitting to provinces, provinces submitting to regions, and highly urbanized areas and independent component cities, those submit to DOH-EB at the national level. So really, DOH-EB is the final clearinghouse of all COVID data. But still the collection, the validation, that's decentralized and the responsibility of each LGU. Okay, next slide, please. So what what data did we have then? So what we used was EB data as of April 7, because our paper was released around mid-April. At that time, there were only around 3,700 cases. And as we know and as discussed in public fora, these numbers may only represent a fraction of total active cases in the country at the time of reporting, especially in the early parts of the outbreak before they ramped up surveillance and the health-seeking behavior of the population became better. So with this data, we can see that at that time, the median case of the ages was really like old. So it was 53 years old. And among those who died, 65. So a lot of 58% of the cases were males, and that's 70% among the deaths. So majority of the confirmed cases then were really from the National Capital Region, whereas if you look at it now, there are other hotspots like Cebu. So as of that time, April 7, we noted that there were around 140 quote-unquote imported cases. These were the cases that had travel history prior to their symptom onset. So this is important because later you'll see that we use this information in our model as a sort of like starting number of infected people. So next slide, please. So here is an overview of quote-unquote SEIR compartmental model. So before we discuss our model, I'd like to just give you a brief overview of what is this SEIR model that you keep hearing everywhere. So really an SEIR model stands for susceptible, exposed, infectious or infected, and removed compartmental model. So what the goal of these kinds of models and standard infectious disease modeling is really to simulate how do susceptible people or healthy people get exposed to the virus or whatever infectious disease, how do they become then infected or infectious, and if they get sick, then how long before they recover or die. So how does it do this? So first, what is compartments, right? So compartment means you wanted to try to divide the population into mutually exclusive health states, quote unquote compartments. So these compartments represent distinct phases in the progression of the disease that are relevant to the spread of its spread in populations. So for susceptible compartment, this is really those who are at risk to get the disease. So the healthy or those who are not immune. So at the start of any outbreak, almost everyone is not immune, and they're all almost at risk. So once you're susceptible and healthy, but you can also get exposed to the virus. And when you're exposed, you don't necessarily have symptoms. So there's a time period before you get symptoms, and that's called an incubation period. Or a latent period is when you're exposed but not yet infectious. So here in the exposed compartment, here are the people who will develop the disease but are not yet symptomatic. Then next, you can become then infectious or infected after the latent period. For example, these are the people who are now ill, so they're actively they can spread the disease. And the last compartment is really removed, which is you can either recover or die. And when you get to this compartment, you don't get out of it. It's like quote unquote an absorbing state. So for any time in an epidemic outbreak, each day the model counts how many people are in each compartment. So that's what we are after, and that's how we can project, okay, on this day of the outbreak, how many people will be infected, removed, or exposed. So next slide, please. So the next slide, for those interested in really the math, I'll try to lay it out in an easy way para you can have the intuition. So in the SEIR compartment, because we're interested in how many people are there in each compartment each day, so there are allowable movements. So if you started susceptible, you can also move to become exposed to infectious to removed, right? So number of people who move between compartments or across the compartments as designated by the arrows is really governed by mathematical equations. So the mathematical equations are not that difficult naman. So let's try to give an intuition to the audience. So from susceptible to exposed, movement is really determined by the prevalence of disease. Or if you see the term I over M, that's just what proportion of the population have a disease, right? So among those infected, they can infect susceptible people. That's a term with the S, right? And then if infected people contact susceptible people, beta is the symbol that stands for what proportion now of the susceptible will get the disease. So it's really just a proportion of disease times how many susceptible times what's the probability that people will get infected. Okay, so beta is just the probability of transmission, and that's what you hear that is affected by the basic reproduction number. If you've heard the reporting of the R naught or the effective R, and it's also a function of how long people are infectious for. Say they're not isolated early, or say they are isolated early. So that's the first part. The second part is if you're exposed and you have the disease, what determines whether you now move to becoming infected or symptomatic? So that is determined by, from literature, the latent period of the disease. So that means if, for example, the latent period is around 3 to 5 days, so the probability of you moving from exposed to infectious is just 1 over that duration. It's the same as saying if, for example, if people exposed to COVID take 3 to 5 days to show symptoms, every day then, around 20% of the people will move from exposed to infectious. So ganun lang po yun. Same thing when infectious are recovered. Based on UHEV data, we have an estimate that it's around 10 to 12 days before they move from infected to removed. So ganun lang po yun. Next slide, please. So next slide, these are also an important underlying assumption with these kinds of models that we have to convey. So it assumes that actually, everyone in the population, they will contact each other with the same frequency, intensity, and duration. But realistically speaking, we know that's not the case, but it's an inherent limitation in the model, in the way of this modeling. And then for the other one is, I mentioned that there are durations that we assume before people move from compartment to compartment. Throughout the model, we assume that duration does not change. So that means it's applied whether you're young or old, and whatever day it is in the outbreak. So that's the caveats of the model, and that's standard across all SCIR models. So next slide, please. So for the next slide, here is actually the model we used, our SCIR compartmental model. And really, it's just an expansion of what you saw a while ago, the simplification. So how did we expand it? We expanded it in 2 ways. First is, for the infected compartment, the compartments in the middle, you have like 3 columns, we are able to stratify the people who have symptoms by severity. So that's asymptomatic, mild, moderate, severe, and critical. And also because you have data on how they, on time to event, like for example, as I mentioned, disease incubation, whether they have onset and whether they contact health system, we're able to say, okay, which part of the health system they are currently in, or at least the model is able to simulate that. So the whole model for this is also stratified by province. That is, all calculations are done at the provincial level, and then we aggregate upwards to help sort of relax that assumption a while ago that everyone can meet each other with the same intensity and frequency. Okay, so next slide, please. So next slide is I just overlaid here the essential parameters we have in our model. So how did we what was the numbers that went into the calculations? So let's start with the susceptible compartment on the far left. So at time 0, at day 0 of the outbreak, which is January 15, 2020, we assume that everyone in the province was susceptible, so no one had the disease yet. And then next, every day, then we assume that susceptible individuals in a province can meet infected people, and this will come from the imported cases that we saw a while ago, because the epidemic had to start somewhere, right? And it was not organic to the Philippines then, right? So in every day of the model, infected people can meet susceptible people, and they can infect susceptible people with the probability determined by the equation a while ago, like the betas and the effective reproduction number. Okay, so accounting for these imported cases and the parameters from literature, so we calculated and and calibrated the model, such as we found that in the NCR, actually, if an infected person would meet a susceptible person, the probability that that healthy person would get infected is around 40%. And this kind of translates to if an infected person, one infected person can infect around 3 to 4 other people on average without intervention. So that's what the numbers between susceptible and exposed just means. Okay, so when you're exposed and you don't have yet symptoms, it takes around 5 to 6 days before you show symptoms. And once they show symptoms, the distribution of severity is 25% of them will be asymptomatic for the whole period, based on literature. 55% will be mild or moderate, and 15% will be severe, while only 5% will be critical. And then once that they get their symptoms, it takes around, then the data from April 7, it took around 6 days before people could go to the health system for consult or testing. Then around after consult or testing, it would take around 5 days to get confirmation of whether they had COVID or not. Then among the people who got their lab confirmation, they can be at home quarantine or they can be hospitalized. Among the severe and critical, case fatality was around 15% for severe, and for the critical, 55%. And then for these people, if you were mild and moderate, it took around 10 days for you to recover. So we don't assume that people who are symptomatic or mild moderate die, only as severe and critical. And then, unfortunately, the data that then showed that if you had severe and critical disease and you died, it was very fast, like around 5 days. So next slide, please. So to really inform potential interventions, then early in the outbreak, we thought of these sets of scenarios, a total of 14 scenarios broken down into 5 sets. So the letter suffixes indicate the length of ECQ. And so A would be the status quo then, which was a month of ECQ. And then additional 2 or 4 weeks of ECQ. And then the scenario numbers represent really what sort of interventions we were looking at. Higher number scenarios were numbered that way because they represented additional interventions. So, for example, scenario 0 S0 is what if we didn't do anything, no intervention, just like as a base for comparison for everything that we will be intervening on. So for scenario set 1, which was ECQ, then it approximated the current conditions. So turning on ECQ means restricting interprovincial travel, closing contact points such as schools, work, and households. And then the symptomatic cases are isolated when they contact the health system, such as going to the emergency room. And also there's an assumption that majority of the people, 95% of them, would comply to the ECQ requirements that only one person in a household could go out. Okay. So post-ECQ for S1, we assumed that everyone is back now, free to move, back to status quo. So that's scenario 1. Scenario 2 is what if you add now better testing? So what does better testing mean? Better testing meant then that in any extension of the ECQs or post-ECQs, our turnaround time for laboratory confirmation would just be 4 days or 2 days. And that we would have a strong isolation protocols for those who are tested. Okay, so the S3 scenario just adds, so what if now we don't just isolate at testing or like confirmation for the test, but earlier at symptom onset? Okay, so what if we were able to do that around 50% for all targeted COVID patients or people who were exposed? So S4 and SS5 was something that the sub-TWG of the IATF requested of us. It was, so what if we extend the ECQ, but we lifted that part of the population could go out, like around 50%. But we kept up better testing and isolation at symptom onset. And actually, what if we improve that 70% of everyone who were exposed, we could isolate at symptom onset. So these are the scenarios really. Yeah. So next slide, please. So next slide is a summary of the projections of the what we call the epidemic curve for the different scenarios. So let's start with S0. So S0 is the gray curve. In the x-axis, that's just time, right? So time throughout the epidemic, projected from January 15, 2020 to January 15, 2022. And then on the y-axis is just how many active cases are there in that day, right? So for the gray curve, the no intervention, what would have happened was, at least projected, that in August 2020, we would have the peak number of cases, the most number of cases in the whole epidemic. And that would be around 20% of the whole population of the Philippines. However, so with the scenario 1, we have the blue curves. So what if we had the ECQ, right, which we did implement? So we see that the height of the curve really was lower compared to the gray curve, right? So then if we had done ECQ as we did, the peak would be in October, and we will only have a peak of around 8.5 million cases. So that's like less than half of the no intervention scenario. And then if you see that there are different shades to the curves, that is what if you extended ECQ. So the curve height would remain the same, but the curve would just be delayed. So it's as if we are buying time with the ECQ, right? So in the green curves, that represents, in the purple curves, that represents scenario 2. So what if we coupled ECQ with better testing and turnaround times? So similarly, we would have a peak in October, but even less case, around 6.6 million symptomatic cases. So for scenario 3, what if we have rapid isolation of cases? So that pushes down the peak even further to only 5.2 million cases, and the peak is later in November, right? Scenario 4, there is sort of an overlap with scenario 3, meaning that even if we partial lift, as long as we can keep up with the isolation and the testing, actually the peak date and the peak number of cases is not that different. And scenario 5, the red curves, is the ideal. So if we partial lift and if we had better testing and isolation of around 70% of the cases, the peak would be less than 1 million cases, and that would be around June next year. So that's a summary of the results we have. So next slide. So how did our model do? So the projections were made around mid-April, right? But it's now May. So just to remember, a reminder that our model is calibrated based on the number of deaths. So that means that we run the model, and then at that time we try to check, does the model agree that today these are the number of deaths as reported by DOH? So now that we are out of the period where we were matching our projected deaths with DOH data, how did it fare? So it looks like for our models, we have sort of an overestimation of the current active number of infections. So for our scenarios, 1C and 3C, we predict that there are around 12,000 cases, supposedly for last Monday. But the report of the OH is there are around 8,400 cases. But we also have to remember that not all cases are captured by the system because of testing, although that has improved greatly. And in terms of deaths, it seems that we have overestimated a bit, but not by much, because our projections for last Monday was 850, around that, but reported by DOH is around 730. So in a sense, the judgment is our model is doing okay. Maybe. Yeah. So next slide, please. So, but really, the key message is, in terms of trends, even if the model of the data is old, aggressive efforts in the post-ECQ period to isolate at least 70% of infectious cases through what we have actually been doing, and the DOH has been doing, better contact tracing, social distancing, isolation, reducing the time to seek care and to isolation is really necessary to suppress the outbreak. Like extending the ECQ without mitigation measures just delays the progression of the outbreak, and we will still get a large number of cases. So the key would be vigilance in mitigation efforts, really. Okay, next slide, please. So now we go to, so if we have these projections of the number of cases, what resources does the health system need to address COVID-19 cases? Next slide, please. Using the projected number of cases from our model, we try to estimate, at least for the cases that require medical intervention at healthcare facilities. To do this, we assume the following. So we assume that all symptomatic cases, they will present on an outpatient basis at emergency rooms or facilities to be triaged, and they will be triaged for severity. And only those that are severe or critical will be hospitalized. Mild and moderate cases, as was practiced then, were discharged for home isolation. Then severe cases who present with severe pneumonia will may actually need critical care, such as ICU. And then part of those who will need an ICU will also need a ventilator for acute respiratory distress syndrome. Okay. Next slide, please. So these are just our assumptions. We want to be transparent about the ratios we used. So at the outpatient triage, these are the number of staff we need for physicians, nurses, auxiliary staff, and such for a number of patients. And this is also the number of PPE sets you would need. So for inpatient wards, there's also a ratio for the doctors and nurses. That's 1 to 6. One doctor for 6 patients, 1 nurse for 3 patients. Intensive care unit, the same. Now you need a lot of medical specialists for this especially. So these are just the base numbers, and you can review the assumptions in our paper. We hope that's transparent for you. Next slide, please. So the next slide is just a summary for each scenario. At the peak day, how many hospital beds, ICU beds, ventilators, PPE sets, and human resources do we need? So the numbers are quite large. So just looking at the best case scenario of scenario 5B or 5C, the country would already require something like 182,000 hospital beds, 55,000 ICU beds, 30,000 ventilators, 88,000 doctors, and so on. But if you look at studies that have checked, so what are the current resources in the country, there are only 61,000 level 2 and level 3 beds. And the number of ventilators is around 1,800, but I think that's still an undercount given the lack of reporting of hospitals. So these are really big numbers, but really at the end of the day, what it's just trying to say is the health system at its current capacity cannot meet demands of the COVID outbreak if these projections did come true. So the caveat is really these simulations, they're all modeled scenarios with aggressive efforts in the post-ECQ period, better social distancing, enforced isolation, reduced delays for seeking care. Such resource costs can surely be avoided or drastically reduced. So that's the caveat I want to say. Next slide, please. So we also try to see with the PhilHealth releasing case rates for those who are hospitalized, how much would it cost PhilHealth if they reimbursed all COVID patients, and if all COVID patients actually did claim their benefits, right? So the PhilHealth case rate is something around 300,000 for severe cases and around 780,000 for critical cases. And in all scenarios except for S5, it's really an astronomical amount. And even for S5B, that's around 206 billion and 268 billion. For reference, in 2019, the operating corporate budget of PhilHealth was around 175 billion. But I think since then they've been given a lot of new appropriations and war chests to subsidize COVID care in the country. So next slide. To summarize, for all scenarios that don't successfully isolate at least 70% of infectious individuals early, the demand for healthcare resources really at the peak of the outbreak will far exceed available supply in the health sector. Only in the S5 scenarios does it present a manageable timeline where we can scale up health system capacity within a year to a level that is actually reasonable, in that after the outbreak, these are still usable. For example, if we address the gap in hospital beds, the system would have something like a ratio of 1.7 level 2 and level 3 beds per 1,000 population, compared to our current supply now of 0.6. And to give context, in other countries, they have around 2 beds per 1,000 population or more. Okay, so that is the key message of health system, the health system portion, that we need to really do the mitigating measures to be able to cope and provide the demand that will occur if the outbreak proceeds at the paces we saw with our scenarios. So next slide, please. So now for the projected economy-wide impacts, here is Dr. Abrigo. Mike?
Thank you so much, Jhanna. We all know from our experience in the past about 2-3 months that this pandemic is not just an epidemic on the health sector, but it also has important impacts on the economy. And therefore, in the economy, it has other spillovers to other parts of our lives. Next slide, please. Uh, an easy way to visualize this potential impact of COVID-19 on the economy is looking at this graph. This is from the Google mobility data that they've published. They update this regularly. So, where are the Filipinos at the start and during this epidemic? Uh, During the start of the epidemic, early March, you see at baseline, walang masyadong pagbabago. But then, with the imposition of ECQ, first in Manila and then in Luzon, then eventually, as we all know, that uh, in the whole Philippines, much has changed in where Filipinos are going. Look at retail and recreation. It has plummeted by 80%. Grocery and pharmacy, 60%. And next slide, please. Workplaces, 70% people are staying inside their homes. So 40% increase. Next slide. So the idea that the COVID-19 is not just a health sector issue, but also an economy-wide issue uh, is shown in this graph. So we explored what is the potential impact of having these epidemic in the Philippines on employment. So what we did was we have that population level SEIR model that Jhanna discussed about. We linked that with a microsimulation SEIR model. So from the population level, we have these individuals. Because from the population level, we don't see sino ba rito sa mga nagkakasakit ang katrabaho, sino nag-aaral. And we can see that in a microsimulation. And that's what we did. And from our simulation, we found that those who are affected, if we count only those people who are affected by the disease, ibig sabihin sila lang yung nagkasakit. Sila mismo yung tinamaan ng sakit. Our estimate is that about 13% that our employment to population ratio would go down by about 13 percentage points. So that's about a quarter of our EPRs if we don't do anything at the peak day. So 25% of our labor force gone. But what if we impose other mitigation measures? Because we know na, syempre pag nagkasakit yung anak mo, even if you're not the one who is sick, pag nagkasakit yung anak mo, yung mga nanay, yung mga tatay, hindi sila makakapasok kasi they have to take care of the children. Or what if we impose yung stricter na since pero may sakit sa bahay nyo, lahat kayo hindi pwedeng lumabas. So lahat kayo isolated. So that would ground the whole labor force for that household. And if we have that, our estimate is that at the peak of the epidemic, if we don't do anything, uh, the employment to population ratio would go down by as much as 30 percentage points. So 30 percentage points, if we compare that with our actual EPR of about 60, that's half of our labor force gone because of the epidemic. And that's just the immediate effect of the epidemic. We all know na there are other mitigations that we have done like ECQ, that also affects yung mga kabuhayan, yung labor supply ng ating mga kababayan. And these has important spillovers to other parts of our lives. So kung walang trabaho, walang kita. So kung walang kita, that would affect yung kakayanan ng mga household to buy goods and services in the market and therefore their welfare. That would also affect yung production of goods in the market. So kung walang workers, sinong gagawa ng mga manufacturing? Sino ang tatanim ng mga agricultural products? And then ultimately, these would affect government revenues kasi walang maitax sa production, walang maitax sa household income, and down the line that affects the ability of government to provide services that it usually provides. Next slide, please. So having that in mind, there are many levers that can be done by government. And well, one of that, of course, is ECQ. But when we were doing this, we were trying to think of what could be the limitations of the potential interventions, potential levers that the government may do. As we know from the literature, during the recent Ebola epidemic in Africa, uh, maraming namatay because of the epidemic, Ebola. But then there are also spillovers into other sections of society. Marami ring namatay na hindi directly because of Ebola but related to Ebola. Namatay sila kasi yung resources that should have been done for other services, for other non-Ebola services, hindi na naibigay kasi yung focus ng gobyerno, ng community is more on Ebola. So uh, nakalimutan yung mga ibang parte na importante din kasi we should remember that COVID is not just a disease in the Philippines. It is one, but it's important, but it is not the only one. Okay, so here's just a rundown of the potential limits that we have thought about. One is that in ECQ, we should remember that 3 in every 5 Filipinos have limited capacity to subsist without additional support. So we were using Dr. Albert's middle class typology, and based on his typology, we found out that about 3 in every 5 Filipinos, yung kanilang kita, kaya lang, yung isang buwan nilang kita, kaya lang mag-subsist for 1 month or less. And that's an important issue, and the government has tried to address that with the SAP and the other goods that it is providing. Another limitation is that alternative sources of income are not equally available among different households. We are saying this because, for example, SSS and GSIS, we know that only 2 in every 5 households have at least one family who's a member of either SSS or GSIS. And with SSS and GSIS, of course, you can pwede kang umutang, pwede kang mag-calamity loan, but then it's not available to everyone. And you would expect that the poor households would have less access to this because they are less likely to be in the formal sector. Another important issue is that remittances may not be at the same level as we've thought it would be. I'm saying this from the point of view na if you remember the 2009 global financial crisis, we were hit hard in the export side, even in the consumption side. But what has tied us over during that time is that we have a lot of international migrant workers, and if you I have not shown the graph here, but in 2000 to 2009, 2010, nag-spike yung ating remittances. And I don't think that we can expect that during this time, because during this time, even their livelihood are at risk. We've seen news reports na yung mga seafarers natin are going back to the Philippines. One, yung mga nasa cruise lines, they're going back kasi yung mga cruise lines are grounded and no one is going to cruise. And another because of dampening of global demand. So yung mga nandun naman sa mga ang tawag dito, yung mga ships na nagde-deliver ng goods across the oceans. Because of slowing demand, grounded din yung mga ships na yun. Next slide, please. During the start of this epidemic, before tayo mag-ECQ, we were actually very hopeful about telecommuting arrangements because we thought that this epidemic has forced us into this experiment that we could tinker with telecommuting arrangements in work and in school. But when we were looking at the data, we realized that may not be possible for everyone. First, there are just jobs that you cannot do remotely, like manufacturing. You need to be there in the plant to do everything. If you are studying, if you have a lab work, then you cannot do it at home because wala ka ng mga gamit. But even the usual stuff na you can do online, there could be a problem because not everyone has access to internet, not everyone has school. We actually have these statistics from the Family Income and Expenditure Survey that only about 1% of the poorest households have computer. So that is a reality that we must face, even if there's this great potential from telecommuting. And finally, one of the, I guess we were fearful about was that limiting travel. While we think that this is very important in limiting the spread of disease, these may have strong negative implications on the ability of consumers first to access goods in the market. We've actually done this small sort of survey among RHUs, barangay health stations, and what we realized was that bumaba yung number of people, although this is just based on reports, that bumaba yung mga number of people, pregnant women, and even those who have children, who go to the rural health units and the barangay health stations for shots, for immunization, even for consultations. And that is a big problem. It may not be a big problem now, but it will be a big problem in the future for these children who are not able to be able to get these important services. And also, these has important implications on the delivery of essential resources. So just last night, we have this report in the news. These farmers from up north, from Benguet or Ifugao, who cannot bring his produce, tomatoes, to other markets. So ang ginawa lang niya, tinapon lang niya. So sayang siya sa ating lahat. It's a loss of our society. Next slide, please. So going now, we want to capture those ideas, but unfortunately, we cannot capture all those kasi magkakaibang mga ideas yon. So to the extent possible, we try to model that using Leontief input-output model. This is a standard model in economics. So what we do is we estimate what if bumaba yung consumption? Kasi nasa loob na ng bahay yung mga household, hindi sila pupunta sa sine, hindi sila pupunta sa park, walang bumibili ng masyado ng bubble tea. So what would that entail? What would that mean for the gross value added? Gross value added, ibig sabihin, ito yung kita ng mga tao in terms of rent, in terms of compensation of employees, wages, even taxes for government. Consumption, we look at the potential impact of loss in consumption and exports. For exports, we know na walang katulad itong COVID-19 Philippines in the recent year. So what we thought about as a similar case would be the 2009 global financial crisis. And during that time, our export was hit bad. And yung namang household demand, we link that We have these model, the SEIR model, and we linked it up with the microsimulation model, and we are able to get ilang tao yung mawawala ng trabaho. And from there, we try to infer how much that means in terms of losses and consumption. And that goes into the model. Next slide, please. So this is the modeling strategy that we have. So we started with the epidemiology. So ano ba yung progression ng disease, ng pandemic? And then we input that into an agent-based microsimulation SER model so that we would know ilan ba yung mawawalan ng trabaho from the disease and from the community interventions like ECQ. And then we have these exogenous assumptions about how would exports change, how would household income change because of the employment. And then from there, we back out, magkano yung kailangan mong bayaran na renta, magkano kailangan na bayaran na wages sa mga trabahador. Next slide, please. So in our baseline models, we have three assumptions. So we have the worst case, moderate case, and base case. And the moderate case and the best case are just a proportion of the worst case. For the worst case, pinag namin siya sa scenario S1B that Jhanna discussed. For the rest of the world, we assume that the pandemic will not be contained this year, and the global economy would slow down into a recession. And based on S1B, we projected that the annual average labor supply would go down by about 20%, and this translates to about 5.3% reduction in household consumption. In the export side, we assume na it will be in the 2009 GFC levels. Ganun kalaki mawawala sa exports natin. For the moderate case, pinag namin siya sa S3B, so there's an improvement in testing and isolation. And we assume that the pandemic would be contained around the world by third quarter. So consumption, based on our projection, so about 3.7% reduction in household consumption. For the export side, we assume the 50% of the worst case scenario. Next slide, please. And for the best case, pinag namin siya dun sa scenario S5B where you have better contact tracing, 2 days lang na-isolate at symptom onset, na-isolate mo na yung 70% of the cases. In the rest of the world, we assume that by second quarter, matatapos na itong pandemic. And based on that, the result was that there would be a 0.7% reduction in household consumption. And in the export side, we assume na 10% lang of the worst case scenario yung mangyayari sa ating exports. Okay, next slide, please. So these are important caveats that we should always remember, that I should remember and everyone should remember when interpreting the results. First is that the estimates are only indicative. It does not capture much of the potential impacts of COVID-19. So some of these impacts would be in the form, of course, on wages and income and other forms of income. But then there are other important effects that could happen down the line, like because we were not able to provide for the critical services, goods for children, then it would affect their development, and this would affect the Philippines in the long run. So yung mga ganon, hindi namin siya nakuha. Second, we excluded yung mga expected increase in healthcare demand because of COVID-19. So we know na pag nagkasakit ka, COVID-19 is very expensive. But then sa other side naman, there are reports na yung mga ibang sakit na pwede namang hindi pa ma-hospital, pwede pang maghintay, hindi mo na sila pupunta sa mga hospitals. And somehow we've thought na it's difficult to estimate that at this point, kaya hindi namin siya sinama. And finally, we've intentionally biased our estimates to be conservative, to be on the low side. So parang this gives us na potential range na it cannot be lower than this because we're trying to be optimistic. So this is in the lower end of the projected impacts. Next slide, please. Okay, so here are the results. So based on our estimates, we could lose as much as 2.5 trillion pesos. As a share of our GDP, this would be about 13%. So that's quite big. Pero sa worst case, it could be as small as 1.4% of GDP. Based on our projections, the worst hit would be manufacturing, trade, and other services, but there will also be a significant impact on mining and quarrying if we would look at it in a share by share basis. Okay, next slide, please. So this is another projection that we did for the sub TWG on data analytics for the IITF, because they were asking what is the potential impact of extending the ECQ. So what if there's no extensions? We stick with the original mid-April deadline. What if we extend it by 2 weeks and now extend it by 4 weeks, which is what we actually have now? And based on different scenarios about what the government will do. So will there be an ECQ? Will there be better testing? Will there be isolation at onset? How large is it, yung compliance? And based on our estimates, what we found out is that an additional month of ECQ costs the economy about 150 billion pesos. So it actually, extending the ECQ buys us time, and it's really literally buying time at a ticket na 150 billion pesos. So expensive, and we thought that this should be really worth it if it's worth 150 billion pesos. And next slide, please. So the key message from this is that COVID-19 is not only a health sector issue, but an economy-wide issue. And based on our assumption, based on our projections, we could lose about as much as 2.5 trillion in the worst case. And as I've mentioned earlier, this we are trying to bias this the low end, so it could be actually worse. And based on our projections, the biggest losers, if I may say, would be manufacturing, wholesale and retail trade, and other services. The bottom line here is that from the last slide before this is that given the same set of mitigation measures, extending the ECQ by 1 month, wala kang ginawang iba, extend mo lang, does not change the trajectory of the epidemic. It only costs us 150 billion. So if it will be costing us 150 billion pesos, then we should be doing more than just extending. For the next set of slides, Dr. Ulep would present. Valerie?
Thank you, Mike. Hello. So thank you, Mike. So for the recommendation, we just want to note that this or the recommendations were developed during the early stages of the pandemic. So I think some of these recommendations are already incorporating in the government strategy. So it might just be a reinforcement of the idea. So next slide, please. So there are basically two general recommendations. So the number one is to really maximize the implementation of ECQ. As Mike suggested, ECQ is very expensive. Although it's effective in reducing community transmission, it's very expensive. It has devastating impact on the economy and population health, especially mental health, etc. That's why we need to optimize and maximize it by better enforcement. The second is that while we are in the ECQ, again, this recommendation was developed during the stages of the pandemic. Now we're graduating to a different kinds of quarantine. So we need to plan a gradual and calibrated transition from ECQ to a risk-based strategy. So when we do this, we need to start planning when is the best time to transition and what is the criteria that we need to use in getting out of this phase or suppression stage. Next slide, please. So during the early stages of the pandemic, we tried to list down some of the criteria in lifting the ECQ. So here are some of the criteria. So number one is that there should be a clear evidence that the transmission is controlled. Second is that there is a sufficient health system capacity. So I just want to highlight here that when I say health system capacity, or when we say health system capacity, it's not only hospital capacity, but public health or community health capacity. I will try to explain that later. Third is that there is ability of the system to protect the vulnerable population when we actually lift the ECQ, specifically health workers. Fourth is that workplaces are very prepared in an impossible resurgence of cases. Fourth is that local governments are very well prepared. And lastly is the people are prepared of the new normal. And I think most of these are in fairness to the Department of Health and with the government, I think they are trying to address all of this as we live or as we transition into a risk-based strategy. Next slide, please. So number one, so I want to tease out a bit those recommendations. So number one is that there is a clear evidence that the transmission is controlled. So initially we come up with, or we suggested 3 indicators of or how do we know that the transmission is already controlled? So number one, there's a significant and consistent decline in doubling time. Second is that the significant and consistent decline in R0, as what Jhanna was explaining a while ago. And there is a significant decline in positive tests. So initially, during the earlier stages of the epidemic, our positive test was around 17%. 15 to 17%. Yesterday, our positive test was around like 4%. So what I'm trying to say here is that you're actually expanding the number of tests, but your numerator, right, should be maintained. Next slide, please. Next slide. So next slide. So the second criteria is there should be a sufficient health system capacity. When we say health system capacity, it's not only hospital capacity. And I think the last 2 months, I think we're ramping up a lot of our hospital capacity. We're buying ventilators, we're buying isolation beds. But I think it should go. We also need to ramp up our community health capacity. So this includes the capacity to do testing. I don't want to use mass testing. It should be massive testing, the capacity to do massive and rational testing. Second is the capacity to trace. Third is the capacity to isolate. Fourth is the capacity to treat. And fifth is the capacity to track and monitor. Again, I want to tease out a bit these health system capacity. Next slide, please. So number one, so there should be a sufficient health system capacity. For this one is to test. Initially, during the earlier stages of the pandemic, so the DOH was asking like, how many tests do we really need? During those times, the number of tests conducted by our ITM was around 500, if I'm not mistaken. But now it's already 8,000. But based on our calculations, we needed around like 10 to 15,000 to actually test those with symptoms and with those close contacts. So now we're around like 8,000 tests per day, and I think the government is aiming 30,000 per day. And the second recommendation under this one is the government should have a clear strategy on how to actually democratize testing by incentivizing local governments and private sector to expand testing infrastructure. So looking at those possible red tapes and other forms of barrier for the government, for the private sector, or for local governments to actually expand their testing capacity. But one thing we realize in the last few weeks of this epidemic, it's not about just building laboratories and buying test kits. Apparently, we're actually lacking of molecular biologists, of medical technologists to do this tests. And these tests are very complicated tests. So it's easy to do. It's easy to say that we need to do massive testing, but there are a lot of barriers we need to encounter, that we've encountered along the way. But I think the government is I think should be applauded for increasing the number of tests from 500 to 8,000, but that's not enough. Um, 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 Enough. So I think another strategy under this is to actually use PhilHealth strategic purchasing power to actually allow the private sector to expand testing. So next slide, please. Next slide. Um, Can you go back to the previous slide? Oh, sorry. So the next strategy is the capacity to isolate. So initially, the WHO, the previous slide, please. So initially, the WHO suggested this strategy, like test and isolate. But I think the strategy should be the other way around. We need to isolate and test, right? As if you've seen the model, we don't need to wait for the test to isolate because we are running out of time if we do that. So I think we need to change the narrative from test and isolate to actually isolate and test. So if you have that symptom, we need to isolate them immediately. And I think we haven't changed that narrative because I think we're too much focused on testing, but I think it's important, but it's important to send the message that isolation is actually the primary strategy. Initially, there is the Department of Health was also suggesting home quarantine, but I think we need to shift that policy to facility base, right? I think if you look at the experience of other countries, especially Wuhan, they really invested in facility quarantine more than home quarantine. I think in the case of the Philippines, I think we should also think about if home quarantine is actually the way to go. Again, one opening here is that we could actually use the private sector to help us build isolation facilities, as you've seen PhilHealth and isolation package. And I don't know why why private sector are not investing in isolation facilities, because PhilHealth will actually pay for them. So I think it's also important to use that opportunity, at least by the private sector, to expand these important strategy. Using the private sector to expand this strategy. Next slide, please. I think, can you go back to the previous slide? I think previous one more like the capacity to trace. Yeah. So the next health system capacity is actually to trace, and actually this is very important. So I call this like mass tracing instead of mass testing. I think it's important that we invest a lot of contact tracing. So I think the DOH already started thinking about this, and they said that we need around one contact tracer for every 800 households. And if we do this, for example, in Quezon City will need around 2,000 to 3,000 contact tracer. But LGU should think about this as a very important investment as we move from ECQ to risk-based strategy. In many countries, like even in countries like the U.S. or state like Massachusetts or New York, there's started to hire a lot of contact tracers. So I think we should start investing on this. And the good thing about this is that as we have additional 2 more weeks, the government or local government should start building its army of contact tracer. And and after May 31, we have enough contact tracers to actually do the surveillance as we move to GCQ. Next. Another important capacity is we go to the hospital setting, is the capacity to treat. So the government should establish COVID referral hospitals all over the country to promote efficiency. So I think this is actually a very to me it's a silver lining, because I think we are realizing the important features of the UHC, which is actually referral system. So and I think this is an opportunity to do it, is to build referral system to make the system more efficient. So we are not putting all COVID patients with mild symptoms in hospital. We should put them in an isolation facility, and those who are severe will be put in hospital. So we can actually rationalize our capacity to treat. Obviously, as what Jhanna suggested, we need to invest a lot of isolation ventilators and critical equipment. And to me, to us, it's fine to invest in these, because if you look at our current supply, it's very low. So we can still use them even after the pandemic. Third is that the government should start creating a standard treatment protocol for treating COVID to improve the quality of care. Next slide, please. Next slide. Another one is the capacity of the system to monitor. Can you go back to the previous slide? Can you go back to the previous slide? Yeah, so the capacity of the health system to monitor. So the government should establish robust IT system to actually monitor the trajectory of new cases real time. I think we've written this like a long time ago, but I think we've now realized the importance of this. Especially after the ECQ, we might see resurgence after 2 weeks, and we need to catch that resurgence after lifting the ECQ. If we don't have a very robust IT system, we might not be able to see that resurgence right away. So if you have good IT system, and if you see rapid rise in cases real time, then we can actually we would know what interventions to do. We need to recalibrate again our strategy, and real time reporting is very important. Next slide, please. Next slide. I think there's a lag. Another criteria is there's the ability of the system to protect the vulnerable population. If you look at the number of cases, around 20% of our cases are health workers. I think our hypothesis is that because we are actually over testing, because health workers are our priority. If you look at the testing protocol, it's in the priority. So we're also getting many patients. Many health workers positive of COVID. So we need to protect them. So number one is that there should be enough supply and buffer of PPEs. The government should have a strategic plan to avoid depletion of PPEs. Through exploring local production, importation, and looking at innovations. The third is that the government has has to increase the number of health workers. And if you look at evidence from many countries, overwork and stress is actually one of the risk factors of infection. So we need to think about not only PPEs, but to look at the optimal number of rotation and health and work hours, because they are important risk factor of infection, not only PPEs. Third, another important risk factor is actually the lack or poor infection control in hospitals. So we also need to actually educate and strengthen the infection control programs or protocols of these of hospitals and health workers. Because if you look at the data, I think there is like huge variation across hospitals. So we need to also investigate what's causing that large variation in infection rate. Next slide, please. So I think the DTI is also now doing this. So as we transition, I think we also need to implement religiously physical distancing, basic hygiene, like hand washing, temperature gathering, should be in the workplace. Ability to implement nudges to ensure employees abide with public health interventions. Workplaces has established outbreak strategic infection control plans. And I think there are good protocols on this. I think Taiwan and Korea, for example, listed down some of the important protocols on workplaces that we could just actually copy and readjust with our own setting. But if you look at those guidelines, it's actually like this, and so this should be followed by by employees as we transition to ECQ. Next slide, please. I think that's it. That's it. So I think those are our recommendations. So thank you. Over.
Well, thank you very much, Mike, Val, and Jhanna, for your comprehensive presentation. So, folks, we are now in the open forum. And for those who missed hearing about our house rules, if you would like to raise a question or express a comment, just use the our chat box, which is located at the lower part of the screen. If you will notice, there are icons at the lower part of the screen, and the first from your left is the chat icon. So just click that, and please type your name and your affiliation, and you will be called for your question or for your comment. Okay, since there's no name yet in our chat box, let me ask the first question. We are now moving, and I'm referring to Metro Manila and other selected areas. Metro Manila and like Laguna are moving towards a modified community quarantine, while other areas will be placed under GCQ. So how far or how close are we to that ideal best scenario that you reported in your presentation? And which brings me to my next question about vigilance in mitigation efforts. So what can you say about the mitigation efforts that have been put in place so far, and what do you think are the gaps that needs to be filled? Over. Any one of you can respond, Mike, Val, or Jhanna, please.
I'll respond first, and maybe Val can have more insights. Well, we should recognize na we should recognize when there are things that are done well. And I guess DOH has done a lot of things. The IITF, the whole of government, has done a lot of things. I guess towards that direction that we want to suppress this epidemic. Uh, from the presentation, if you would remember, time to isolation, time to seeking care at the start of this epidemic was about 10 days. That was what, 2 months ago. And more recent data shows that it has improved a little. It has improved a lot, more than half. So, dun sa latest na nakita kong data is about 4 days. Uh, it is a great improvement. But I guess we should also need to recognize that even if it's an improvement, I guess there's still room for more. Ideally, we would want to isolate people the earliest possible. From the epidemiology of this disease, we know that people could be infectious even 2 days before the onset of symptoms. So kaso hindi natin makita yun kasi wala pang symptoms. So if you can isolate them at the date of that date of onset, that would be a lot to be able to curb this epidemic. Val, you may want to say something about
Yeah,
testing.
I totally agree with Mike. I think um, um, we should recognize that although we need to do more, I think we need to recognize the successes of the country in actually suppressing the virus. Although again, I just want to reinforce that we need more. Um, without the ECQ, we would have uh, an exponential growth in your cases, right? But if you if you look at the data, if you look at the data, the number of cases, even though there are delays in the reporting, you would see a non-exponential growth in your daily cases, right? Even if you look at the onset of symptoms, it's exponential growth. So I think that's one of the of the country in actually suppressing the virus. It's not exponential growth, and I think we need to recognize that. But again, I think we need to do more. If you ask me, have you flattened the curve? And yeah, we might have flattened the curve. But I think the bigger question is like, um, are we actually targeting elimination, for example, or like, because when you say flatten the curve, like you don't expect zero cases. You just maintaining a manageable level of cases, which is actually we are doing now. We are playing around 200 to 300, 100 to 300 cases per day, and it's exponential growth. So I think with that, I think there are successes, but again, we also need to dream more, which is to actually start thinking of reducing more of the cases, right? And I think that's why I want to really emphasize the value of a community oriented approach in doing this, better contact tracing, um, you know s- rational testing, because if you look at it, if you were able to isolate 80% of symptomatics, if you look at the model, we could actually suppress the virus. So with better isolation, with better testing, even after ECQ, there's a possibility, there's a huge possibility that we could actually suppress this. And I need to emphasize the importance of community oriented approach in doing this. Countries with good public health system, like for example Thailand, was able to do it. Vietnam was able to do it. So I think like huge investments in public health and community oriented way of doing it, of suppressing the virus, is actually very important. And I think we need to invest on this. We need to do it. And the 2 weeks, that we have time, or the 2 weeks before we lift the ECQ again, we need to ramp up the years of neglect in public health and community oriented interventions, and we need to do that in the next 2 weeks. And it to me, it's scary, but it's exciting. I think we've these are the silver linings, I would say, if implementing the real reforms in the health system, changing the way we see things, the way we see the health system from hospital centric to more community oriented ways of doing things. Most countries around the world with high cases are hospital centric systems, and we need to be more, look at how many Asian countries with strong community health and public health was able to actually, significantly reduce the number of cases. So I think that's just my take on this.
Thank you, Mike and Val. Those are very important insights that our policymakers really need to consider. We have a comment from Dr. Manuel Dayurit of the Ateneo School of Medicine and Public Health. Sir, please.
Thank you very much, and good afternoon to everyone. Maybe I should begin by just congratulating PIDS and the presenters. I guess considering that this paper actually appeared almost 5-6 weeks ago, is really, I guess, a tribute to, in a sense, the study that you made. Because 5-6 weeks ago, I don't think we had, really figured out what was going on. And your paper at the time already sort of structured the thinking. I might also say that a lot that you've presented, including the projections and even the recommendations, are in a sense coming to pass. And that's really what I'm going to address my comments on. And I'll just give three points. I guess my first point is that COVID-19 actually exposed the weakness of our health system. I think it was Mike who said that it's been a neglected health system for decades. And I think this is very, very obvious when you compare the preparedness of the Philippines with other countries like Vietnam, Taiwan, Thailand, South Korea. The capacity that they had to confront COVID-19 when the infection actually became pandemic, I think is testimony to the fact that they had actually modernized their health system. Like, for example, Thailand with its primary healthcare system and even its own laboratory system nationwide has been able to blunt the spread of infection. So with Vietnam, we were, I would say, quite ahead of Vietnam many years ago. But I think they've proven that they've risen to the challenge. And for example, they had only 4 laboratories at the start of the pandemic. Now they have about 120. And they were able to, you might say, rapidly ramp up because of the systems that they had and because they themselves had the capacity to produce their own RT-PCR tests. They didn't import. They actually had the capacity to create it in their country and eventually cascade it to their labs. And I imagine many of these were actually government labs. And for example, the example of South Korea also, we saw how, their testing capacity, which was built from the experiences that they had from MERS-CoV, where over the last 5 years, they actually incentivized private sector to create molecular biology capacity. And I believe even incentivize their students to become molecular biologists. So they now have quite big army of molecular biologists in South Korea is testimony to that building of the health system. So I guess that's my first point. Many countries have really advanced in developing their health system. But now comes the Philippines, we're having to build that capacity in an accelerated fashion. And we're actually building it now. And in fact, ironically, the ECQ has been sort of the time given to build that up. For example, we had one lab doing the tests at 300 to 500 in early March. Now we have over 20 labs. I think by the end of May, we're targeting 58 labs and then more afterwards. So we're having to build that capacity in by ramping up both public and private laboratory capacity. Either expand the capacity of existing labs or actually creating new laboratories. So the partnership of private sector and public sector is only what 5 weeks old, and I think private sector contribution to building this capacity I think is noteworthy. Another point that I might raise in terms of building capacity is the issue of contact tracing. It's impossible to do contact tracing unless you have mobile technology and you have an IT system to support it. And I think we're simply building that capacity now. And I know that government and private sector are actually working together to create this unified data system where all of the inputs from laboratories, from primary care centers, from hospital go into one unified system that's now going to be able to communicate across the various stakeholders so that you can actually identify both the cases as well as the contacts of these cases so that you can actually monitor even these contacts. So that's one of the capacities that's actually being built as we speak. And there are others, okay? And I won't go into that, but I just want to say that, in fact, that capacity is being built now. But my third point is I sometimes wonder if we can keep up with the constant threat of the virus, because it's going to be a huge drain on our resources, particularly at the time where the economy is actually knocked down. And if I might have an analogy, that's eventually the way a person is overrun by, for example, the virus like HIV. The virus just keeps attacking the system, the immune system. The immune system overcomes it. And after a while, the immune system gets exhausted and it actually just, and the person dies. And this was at the early phase of the AIDS epidemic when there was no drug and there was no treatment regimen for HIV. With that treatment regimen, you can now extend the life of a person with HIV so that he even lives a normal life and can even have children and may not pass on the infection to his partner or her partner. But anyway, what I'm saying is, if you use that analogy for COVID-19, we are building capacity, in a sense, strengthening our immune system systemically to overcome that, the constant threat of the virus. What worries me is eventually just running out of resources to do it for both public and private sector. For example, if PhilHealth were to cover, the needed tests, and we're trying to ramp up to 30,000 tests by the end of May, even above 30,000 tests to 50,000 by June, can our system afford it? And therefore, thinking about how you rationally deploy these tests is quite important. And you'd have to balance off the active case finding and contact tracing with, the costs that this will all entail. So I guess I should end with a question. What do you think, given the studies that you've made, and we're now 5-6 weeks after you've made your projections and you've made your recommendations? We're still in ECQ, and we're buying time so that the systems that I mentioned, including the unified data system, eventually starts to function. But what do you think? Can our system sustain it, particularly economically? Thank you.
Thank you very much, Dr. Dairit. Gentlemen, Jhanna, please. Mike, Val, or Jhanna?
Um, Thank you so much, Dr. Secretary Dairit. That was a handful, and those are really nice insights. And I tried to answer the best that I can. First, about our capacity. Well, we've recognized that we're lagging behind in terms of capacity, both in terms of uh, expanding the technology, the use of technology here, as well as of the available people to be able to run the technology. But I guess uh, to some extent, we are a victim of our past successes. So we have this natural barrier that is the Philippines that and to a large extent we were not affected by many of the epidemics that were out there before. We were not much affected by MERS, by Ebola, that has affected many of the other countries.
Yeah.
And to some extent, that is one of our successes. And because some of these countries that were affected now, like Taiwan, Singapore, Vietnam, they were affected greatly by MERS in the early 2000s. They were able to prepare. So nasaktan sila nung panahon na yon, and they ramped up their capacity so that in case na merong ganun ulit, di handa sila. And we don't have that opportunity. We have these epidemics in the Philippines.
Ulan.
We have these small epidemics in the Philippines like TB, ano tawag dito, dengue, but it's not of the same proportion that we have now. So I guess dun tayo nagkulang. And another is on how we value scientists. So we have this presentation before in PIDS where Dr. Bibs Orbeta was looking at how much we are paying, say, life scientists and other professionals compared to other workers. And it's not much different. Kung magkano yung binibay natin sa mga scientists, not much different from what we would pay other workers like clerks and stuff. And I'm not saying that we should pay them more because, well, they're valuable and the other people are not valuable. But to some extent, kasi it conditions the market. If we're not paying scientists, then we will not make scientists because there's no economic value in being a scientist here. Diba? And let me cite this unpublished report by Dr. Albert and others who were working on the supply of scientists in the Philippines, and what they found out and what they were recommending was that some of the insights that I've got from their presentation then was that wala kasi tayong ano tawag dito, wala tayong role model for scientists. Unlike in the 1990s, they have this hypothesis na kaya maraming naging scientists from the 1990s kasi nung panahon namin, nung bata kami, merong matinik, merong siniskwela, meron tayong mga models na gusto natin maging paglaki, and we don't have now, and that does not bode well, I guess, for the future. About contact tracing, I totally agree with you that this would be much easier, faster with technology. But then again, we should recognize that contact tracing is not the end all be all. Kasi after some point, if the epidemic is growing exponentially, then going after that, the next 3 times 3 times 3 times 3 would be a lot of work, and it might be more expensive. And closing down the economy would be much cheaper. But I totally agree that technology is key. And ang pambawi lang doon, for me, I guess, is that kung tutuusin natin, madali lang talaga siya kasi we have this cellular technology which can pinpoint if I know the cell phone number, I can pinpoint saan siya pumunta. But then we need to balance this with our responsibilities about privacy and such. Siguro dun lang. And then about resources and the sustainability of the actions that we are doing. Um, I echo yung mga discussions in other fora where I guess the point here right now is not to grow but to survive. and um, na we need to survive this to be able to grow eventually. But having said that, we need to lessen yung gaano man to kahaba because there is a potential scarring effect in the economy. Kung ang maganda analogy dito that I had with a discussion with other people is that the economy is like a plant. So it can only sustain so much battery. Na pwede mo siyang takin or whatnot, na hindi siya mamamatay. But there will be a point na sobra siyang uh, tinamaan, hindi na siya mag-grow, hindi na siya mabubuhay. So I guess that is my point. Val?
Yeah, I think you've made like a lot of excellent points, Mike. Thank you, Dr. Diary. I think I just wanna, I think, reinforce the importance of human resources, particularly um, um, yung mga hindi natin na nakikita na, I mean, yung when you say health human resources, right, like always think about doctors, we're thinking about nurses, they're very, very important, but there are also back-end workforce, there are important science, investments in scientists. I think that the case of Vietnam, the case of Thailand, if you look at why they have a very strong and robust health system, is because they're invested in a lot of of good back-end workforce, right? They've sent people they send people to Hopkins to study PhD in epidemiology and infectious diseases. They have good health economists, etc. And like, for example, Thailand, Taiwan, for example, their vice president is an epidemiologist. But the thing is, like, if you look at the country, we don't have a lot of these important, technical people who could actually help us in navigating this epidemics. Like, we need more scientists. And if you look at the foundations of Thailand and Taiwan, is that they've really invested in scientists in public health. And unfortunately, we don't have that. We have one of the best public health schools 20 years ago when Rockefeller gave us a lot of money, and we've sent people abroad to study public health. But now we haven't invested in that aspect, in investing in scientists to think about how to navigate this. And again, I really, because a lot of my friends are in Thailand, and a lot of them are really, and if you talk to them, and actually that's one of the primary and or the precursor of a health good system. Obviously, if you look at the history of Thailand, there are important events that push them to embrace primary care. But beyond that, there was really a good investment in back-end workforce, in important scientists in health. So I think we need to start thinking about that, on how to actually build the cadres of scientists who could actually help us navigate this with a different perspective, with a different, so I think we need to think about that. So I think that's my only contribution to that question, is how to strengthen public health and building the cadres of scientists who could actually help us navigate this. Although we have a lot, but if you look at, we have enough, I would say. But if you look at the countries who were successful, was really, they had invested heavily on human resource, not only doctors but physicians, but scientists and other back-end workforce. So I think we need to think about that as we move forward. So yeah.
Thank you very much, gentlemen. Very interesting points. We actually have a webinar on health human resource, a study conducted by Dr. Abrigo. So that's going to be this month of May too. So watch out for that webinar of PIDS. So we have another question, and this time it's from Dr. Romulo Miral of the House of Representatives Congressional Planning and Budget Research Department, or CPBRD. Dr. Miral, please. Dr. Miral, are you there?
Okay. Yes.
Please, your question, please, sir.
Yeah, based on of course the data now available, it seems that the COVID cases have largely been in NCR, Central Visayas, and Calabarzon. So my question was, is placing the whole country in extreme ECQ warranted given the capacity of the government to respond to the requirements of such an arrangement? Because I think, like in China, they only start investigating when somebody already died of it, and that's somehow a confirmation that there's a case of COVID. But in our case, we place our whole country in extreme ECQ, and that would actually have certain implication not only with regards to health, but as well as an economic and social aspect. So my question is, would have been such kind of arrangement been recommended by say PIDS if it had been consulted initially earlier on, and if the government just have concentrated like in these areas, what could have been the result in terms also of health, economic, and social aspect? I think that's my question. Thank you.
Thank you, Dr. Miral. Gentlemen, please.
Thank you so much, Dr. Miral. Well, to tell you frankly, that's a difficult question. Um, First is that hindsight is always 2020 vision. So we didn't know what we know now. We didn't know then what we know now. Another is that, um, well, sige, paano masagutin? I'll just tell you some of the facts, and then maybe you decide on your own if it's the best. But um, one is that during that time, hindi naman alam yung extent ng COVID-19 in the Philippines. So and up to March, we were letting people in from all over the world, and we haven't really stopped our uh, airports. So we really don't know kung nasaan yung mga may sakit. And then March 15, before March 16, we said that we would close Metro Manila and the rest, and then eventually Luzon. And as ano ba, scared people, if I may say, or maybe move people to move out of NCR. And based on our estimates during this time, yung R not in other areas outside of NCR, the rest of the Philippines actually spiked. So from around like 2 weeks before the ECQ, 1 week before the ECQ, nag-spike siya ng 2, almost like NCR. Tapos nag-mellow down siya ulit. And somehow, my feeling, hindi pa natin nababalidate, is that this has somehow spread the disease in other areas. To one extent, maganda siya because that somehow would not overwhelm the health system here in NCR. But in another sense, spread natin yung disease kung talagang nasa NCR lang siya. Now, about projection, what would happen kung hindi natin ginawa yung ECQ? Really, it's when we were doing this paper, ilang beses kaming nagtanong kung ito ba yung results na lalabas natin kasi natatakot kami dun sa results. Pangalawa, una. Tapos pangalawa, what does these results actually mean? We know that these models are mathematical models, and somehow we try to capture all the intricacies of the world in these few equations. And that's really difficult to answer. So what we have now is that we have projections. What if continued yung closing, and what if full lifting, balik tayo sa pre-ECQ days? And based on our models, it could go anywhere. The possibility is malaki. Para siyang hindi yung mga projection models actually, they are not crystal balls. Now we would know the future. These are based on assumptions about behavior of people, and that's difficult to predict. We can assume that this way and that way, and this could give us some bounds. And dun sa bounds na nakita namin, it's really wide. So to answer your question, it's really difficult to answer. Ano ba yung mangyayari sa atin? Economic-wise or health-wise or social-wise? Val?
Yeah, I think when to answer the question, if it's warranted to actually like why a lot of non-Luzon provinces, especially in Visayas and Mindanao, followed ECQ. Like initially we tried to look how many provinces. It's actually like 98% of provinces in the whole Philippines actually have some sort of quarantine, right? I mean, with different levels of compliance, I would say. But it's a very fascinating observation from a sociological perspective, because in our countries, you would see, like in the US, like they really want to remove the they want to really remove the quarantine or stay. I mean, they remove the quarantine, but in the Philippines, the level of risk averseness is very high. So I think I think the reason behind that is because we don't know a lot about this disease. There is no counterfactual. We don't know what would happen if in case na di sila nag-ECQ, like even though in some provinces would have one or two cases, but they still had impose some sort of quarantine. Because again, it's because of the nature of it's because of the speed of the transmission. Even though you have two cases, you would like in the next few weeks you have thousands of I mean hundreds and thousands of I mean hundreds and thousands of cases. So I think to answer your question, if it's really warranted, like um I think it reflects, I mean, the lack of knowledge of how the virus will spread, and the risk averseness, I would say. But I think moving forward, I think that level of risk averseness might have helped to somehow, um, um, to buy us time, a lot of provinces, to give them time. Like for example, in my province in Ilocos, the governor would just say, "Oh, like where can we buy, where can we buy a laboratory, a BSL lab?" Like those things. Like they're still starting to ramp up their laboratories, even though we have only two cases in Ilocos Norte. And to me, those are signals of how those are silver linings of how we should actually prepare the health system, even though you have two cases. But after lifting that quarantine, there are evidence that border control would just delay it. So you would imagine that in Ilocos you might see like a spike in cases maybe a month, 2 or 3 months from now. But that level of risk averseness might have actually helped those provinces to prepare them, right, to know more about the disease, and to ramp up their health system. So I think it's worth it, um, um, but I think we need to start thinking about the future, and I mean a more permanent solution to this, which is more of a public health intervention.
Thank you, gentlemen. Our next question is from Dr. Alali Craft of the UP School of Economics. Dr. Craft?
Hello, good afternoon. Can you hear me?
Yes, ma'am.
Thank you. First of all, congratulations to the writers and presenters of the study. I just have some questions. No? Maybe this is just clarificatory. The first one is regarding the economic model. So I guess this is from Dr. Abrigo. Hi, Mike. So you made some projections looking at the different scenarios of infection, but I'm not sure whether the economic model factored in the stimulus package of the government. As you know, there was a stimulus package that was passed. Maybe the model was developed earlier than the stimulus package. And if so, if it wasn't been considered, uh, do you think that the effects of the stimulus package would be significant? Would at least reduce the negative impact uh, of the lockdown on the economy? The second question is this is a little bit probably technical. Um, there are always recommendations to ramp up testing. So in what Val has in one of the slides, I guess there was a recommendation to ramp up testing to 8 to 10,000 a day, and then as you said, the DOH is now trying to ramp up testing up to 30,000 a day. And I'm just wondering, what is the basis? Is there an epidemiological basis for this particular target? I mean, is it based on, let's say, being able to test the potential infection, or is it being able to test X% of the population? Because I think it's not it's not really clear where that's coming from, and in a way, it's probably for my information because I'm an economist, not an epidemiologist. So I'm just wondering where that number is coming from. Thank you.
Thank you, Dr. Kraft. Two questions from her. Mike first, and then Val for the second question.
Thank you, Mama Lely, for the questions. About the economic model and stimulus package, the short answer is no, we didn't factor that in because I think that came out later mid-April when we've read about the stimulus package. What we were able to factor in, though, that during that time was ongoing, was the potential impact of SAP. Yung 8,000 pesos subsidy for workers. So somehow that is folded into some model because we assumed if a worker loses his or her job, he would only lose 20% of his income. So somehow that would capture that idea. But about the stimulus package, well, I have some of my apprehensions, but this is just me. So my idea of a stimulus package is that you still have these other services going around, para kang status quo, and then you just add more benefits or more services to stimulate the economy. But I'm not sure if what we have now or what is being proposed is actually a stimulus package, because as far as I know, as far as I understood the bill, it is a package that tries to stimulate the economy, but the funding will be coming from other services that is already dapat ongoing. So I'm not sure. Para siyang from one pocket to another, and I'm sure if it's appropriate to call it a stimulus package, if I understood the bill correctly. You know, Val?
Oh, hi. Thanks, Dr. Aleli. So our initial calculation of around 10 to 15,000 was based on the incidence of flu-like symptoms. So we got the data from IHMEs. There's an incidence of like upper respiratory tract infection. So we based that. So that number will be reflects testing of symptomatic patients. So that's why it's important that 8 to 10,000. I mean, the initial calculation is 10 to 15,000 is based on symptomatic patients. We didn't calculated how many do we need to actually, for example, if we move to a more liberal testing capacity of like, okay, let's test all those close contacts, etc. So it would be a different calculation. So I'm also a bit confused when people say mass testing. What do we mean by that, right? But to me, if we actually test symptomatic patients, that's around 80%, like, or let's say asymptomatic is like 25, and the rest like 75, and the like majority will be symptomatic. If we were able to test them and isolate all their close contacts, I think that would be a more efficient way of doing it. So, sorry, I was talking too much, but the question is like, it was based on the incidence and the flu-like symptoms.
Thank you, Val and Mike. We received a comment from Ronnie. I think this is Dr. Ronald Holmes. However, I saw a while ago that he already left. I'm not sure if it's still around, but Yeah, looking at the participants who are still online, he's no longer present. So yeah, he was just thanking us for the invitation, and he said that it was an interesting study and a good presentation. We also received a comment from Dr. Manuel Dairit, but apparently Dr. Dairit also already left. So let me just read his comment, and that was in his comment was in response to Dr. Romulo Miral's question. He said, I think ECQ was a response to a situation where government deemed that it was not on top of a rapidly evolving situation. ECQ was a top-down imposition that was convenient to do before things got out of hand, so to speak. It was also a way of buying time to assess the situation, given that the data at the time was quite patchy. So that's it. Reviewing the our chat box thread, there are no more questions left. Um, okay, so it looks like we have already accommodated all the questions. So if there if there are no more questions, we now proceed to the final part of this forum, and we just would like to thank all our presenters for their enlightening research and everyone who participated in this webinar. Thank you very much, everyone. Ma'am Cel, any final words before we close?
So just wanted to thank everyone for joining us in our first webinar, and we hope that they can participate in the series of webinars that we're organizing this month. So thank you for all their active participation.